audible? I'm audible? I'm indeed very happy to be here to present before you an introduction to cortico basal implants. Dr. Biniraj is a very close friend for many years, and I clearly remember, I think it was sometime in 2009 that I did the first presentation for the Periodontology Society. Then it was not called COPS. It was called Cochin Periodontic Society, but the abbreviation came in later. So I still remember then Nuruddin and Major, all of them were there. I think that was sometime in 2009 in our old IMA house in Kochi. Okay, ever since I've continued with immediate load implants, and it's been 15 years since I've been into cortico-basal implants, having placed close to 18,000 plus implants in the past 15 years. We definitely have considerable experience and documentation. So now I'm here before you to bring in a completely different perspective to the field of immediate loading. Now I want you to, those of you who are here, I want you to just raise your hands who are not familiar with cortico-basal implants. Will you just raise your hand? Okay, I see a few hands. And how many of you are familiar already? Okay. Not familiar. Okay. Now I'll request all of you seated at the back to please move forward. I'll really, you know, this is not a huge crowd, but it'll be really interesting if all of you can come forward so that we'll all sit together and it'll be more of an interaction than anything else. So now, why do you have to listen to this lecture in the first place? You've been loaded with a lot of information on conventional implantology, and all of you are gathered at the fag end of the conference to listen to cortico-basal implantology, and I'm sure it will be quite enlightening and interesting, and it might break up a lot of ideas which you've gathered over the past 2 days. Yeah? So, what are the criteria for success of dental implant systems? Now, these are the answers which I received during my last presentation. I was asking the crowd which had gathered, what are the criteria for success? Now, of these criteria which they've given, which criteria do you think is the most important to decide on the success of a particular implant system? Can any of you tell me? Long-term functionality. Okay. Any other opinion on this? Sorry? Patient satisfaction. Okay. Then? 1 to 12. No, I want you to just take up just 1 point. Just one. I think I'll request the chairpersons, my friends. Predictability. Okay. Major? Minimal complications. Okay. I think point number long-term functionality, point number 7, encompasses all of them. In reality, it encompasses everything else. That is a fact. Okay? So, long-term functionality is the most important criterion in selecting a particular medical prosthesis. Now, that includes several key aspects, which include stability, aesthetics, durability, biocompatibility, easy care and maintenance, and retrievability, of course. All these are covered. Because if it has got to be long-term functional, it has got to be stable, it has to provide enough aesthetics, it has to be durable, it has to be biocompatible, it should be easy to care and maintain, and it should also be retrievable, which is very important, okay? So, now I have something special for you. It is nothing but classic old wine in a new bottle. What is that? Classic old wine in a new bottle. Now, what do I mean by that? We have to go to history. History of implantology. It gives us the tools. Why do you have to learn history? You have to build a narrative. For any science, you have to build a narrative so that you are able to understand the fundamentals well. So it helps in so many ways in learning history. And it was none other than Dr. Linko who said, a careful analysis and understanding of the roots of our history ensures a thorough and thoughtful application of our technology in the future. So we all know that the oldest implants which have been documented, I'm not talking about the successful ones, but history says that ancient Egyptians used implants way back in 2500 BC, and there were so many ways of doing it, and they tried so many things, and finally, it was only in 1943 that the subperiosteal implants or the superplants were introduced. I'm sure all of you, many of you have listened to Dr. Shankaraya's video, would have watched Shankaraya's video, where he talks about subperiosteal implants, which he says is probably the oldest documented functional implant today, which is true. I have seen some of my patients who've been priests, who are working in Europe and in the US. They have come back for checkup, and I've seen fantastically working subperiosteal implant prosthesis. Okay? The only disadvantage, the one and only disadvantage with these prostheses is that the procedure is very invasive. You have to open a flap and you have to make a direct impression. Now, of course, you have the 3D scanning and you have digital protocols in place. It's certainly a lot easier, but still, this is a fantastic system, absolutely no doubt. Then, some of the very successful designs were the Sialom pins, the tantalum tripodal pins, which were introduced. I see a lot of cases even today. There are practitioners of Sialom pins in France and in Germany and in Italy. And Dr. Leonard Linko, he was the one who went outside the box. He ventured outside the conventional things, and he went in and brought in many, many designs. And this was probably one of the precursors of the bicortical screw design, the bicortical screw. Okay? And this later evolved into the bicortical screw. And later, we also had blade implants which were introduced, which were reasonably successful. And then you had the Ramus frame implant. So the Ramus frame implant was also a very successful design, but all these were very invasive, very invasive. And then the transosteal implant, they were all successful, but they were invasive. And then comes Professor Brennemark, who said, no one should die with their teeth in a glass of water. Okay? He brought in the concept of osseointegration. And later, he was the one who was instrumental in documenting meticulously all the work he did. Very much unlike his peers who were working on corticobasal implants. At that point of time, it was never called corticobasal because they didn't really know where they were engaging those implants. So he brought in the concept of osseointegration, and the Academy of Osseointegration was formed, and a lot of theories came out in relation to osseointegration. And almost parallelly, the bicortical screw implant was also being used. But the problem was people didn't know the anatomy in the first place. They didn't know the bone behavior. They were just randomly placing screws, like they put nails into the wall, and some of them worked, some of them failed. They didn't know why it was not working. They just kept randomly placing, and that was it. So lot of researchers were there, and the designs were of, they were multiple designs which came in, and but this is one of the oldest studies which is documenting the survival of these implants for close to 55 years. These screws, which later evolved to become the bicortical screws, which are being routinely used today, and they are probably one of the most successful of the dental implant designs which are available today. There's absolutely no doubt about it. Okay? This is, you should, all of you who are suspicious about what I'm saying, you should make a photograph of this slide, and you should go back and search online to confirm that what I am saying is true. Very, very important. Okay? Those are the photographs which are there in the slide, in the article. And now, all of you would have heard of Pareto principle. Yes? Pareto principle is nothing but 80-20 law. So, 20% of the input brings out 80% of the output. That is what Pareto said. Now, I have to bring in this Pareto principle into, if I am to bring this into the Pareto principle into implantology, I'll say out of 100 implant patients, only 20 patients can be treated in conventional implantology. Am I right or wrong? Okay. Okay. Only 20. Why? Because the remaining 80 are unfit for various reasons. They have inadequate bone, the bone quality is bad, severe periodontitis, medically compromised, or they are smokers, or they have other unfavorable habits. Okay? So that is a problem. So, and finally, most importantly, the people with money have no bone, and the people with bone have no money. This used to be the state. Yes, am I right or wrong? Okay. Okay. So now I come into cortico-basal. Okay? Broadly, implantology can be classified into two. One is crestal or alveolar implantology, and the other is strategic or cortico-basal implantology. Okay? So, here you have I don't think the pointer is working. Pointer is not working. Okay. So here you have the yellowish bone which you see there is the crestal alveolar bone which you see here. That is a crestal alveolar bone, and this is the basal bone, the basal cortical bone. And basically, strategic implantology is nothing but a merger of conventional implantology and prosthodontics and orthopedic traumatology. This is the fact. It's a merger of both. So, alveolar bone and basal bone. You have the alveolar bone where the tooth rests, and the alveolar bone, as you all know, is very soft, porous. It has got a lot of blood supply, whereas the basal bone is very dense. It has least vascularity, and it is the basal bone which remains once the alveolar bone is lost because of bone resorption. As periodontists, most of you are periodontists here, you're all very much aware of this. This is something which you keep seeing day in and day out in your practice. And the implants which we place in the crestal bone cannot be placed when there is a lot of bone loss, as you see here. there you have the only option of placing a cortical implant. Okay? So all of you are aware of the advantages and disadvantages of anchoring it in the alveolar bone and the basal bone. So that is the conventional implant, and that is a corticobasal implant. Just a diagrammatic representation. Okay? These are the conventional implants, and now I have to come to some kind of a pile foundation design. I need to explain with a pile foundation design. So the conventional implants are placed in a position like this in the topsoil, whereas the basal implants are placed in the basal bone, as you've seen here. Okay? So that is the conventional implant, and that is a basal implant. The basal implant, we've bypassed the nerve there. You can see that we've bypassed the nerve. And this slide explains why the basal implant survives. You can see what has happened to the bone around the implant. Can any of you tell me? Bone is resorbed. Why? Because of peri-implantitis. Yes? In spite of that, the implant is surviving. Why? Because it is anchored in the basal bone. It is anchored in the basal bone. Why has the basal bone not been eaten up? Because the bacteria cannot access that bone because there is no blood supply and there is no nutrition for the bacteria. The bacteria just can't eat into the basal bone. So the implant is surviving only because of the cortical engagement. I'm sure many of the speakers who were here today, earlier, they would have all emphasized on the importance of cortical engagement, I'm sure. Now, conventional implantology people have also come into cortical engagement. They accept corticobasal implants now. They've come to a state. So, what are the essential differences between the conventional and the corticobasal? So, in terms of length, they are longer. The corticobasal are longer. In terms of width, they are narrower. When they are narrow, it's much easier to place them with keyhole procedures. Okay? The surface is smooth. The engagement is much deeper. It is engaging the deeper cortical bone. Open versus keyhole procedures. As I was mentioning earlier, to place a conventional implant like that, you have to do an open procedure. Whereas here, on the right hand side where the basal implant is, you can place them employing keyhole procedures, which is a huge advantage. And as periodontists, you're all aware of the RAP phenomenon, the regional acceleratory phenomenon, where you tend to have bone resorption when you open up the bone. You open up the flap and you open up bone. You certainly develop bone resorption. All this can be avoided employing keyhole procedures. Peri-implantitis incidence is considerably low. Why? Because they are highly polished smooth surface implants. Highly polished. And the beauty is, unlike conventional implants where you have to modify the bone to suit the implant, here you are able to select an appropriate design, or you are able to modify the implant to suit the available bone. That is the beauty here. So you don't depend on any extra objects or anything external for the implant to survive. So that is a picture where you see both the conventional and the basal implants in place. So the basal implants are engaging the nasal floor. You can see that here. And the conventional implants are in the alveolar bone. Okay? So they are much longer and much narrower. So now I'll just quickly go through a few important points which you need to understand. First thing is, as I mentioned earlier, keyhole dental implant technique. that is possible. Okay? So the keyhole technique helps in reducing the RAP phenomenon, and it's more or less a bloodless field which you encounter. But of course, it is easier said than done. It's very important that you do a proper imaging before you attempt a keyhole technique, because you are likely to go into some other area, or you may completely lose orientation. So this requires a lot of experience, no doubt. And no bone augmentation procedures. I've already told you this. No sinus lifts, no ridge splits, no bone grafts, and no nerve lateralizations. For example, in a case of bone deficiency, in conventional implants, this is what you do. So you have to build up bone. You have to build up bone. You have to wait for 6 months, and at least 6 months, and then you place the implant, wait for another 6 months, and then only load. Okay? But here, we place the implant, and under the stimulation of the implant, the bone grows, the bone heals and settles. This is what we see. There you see, you can see that there is bone buildup there with conventional implants, whereas in cortico-basal, there is no bone buildup. We are dependent on the cortical bone here. We are not dependent on the crestal bone. Our anchorage is all here in the basal bone. Now, here is a case of full mouth rehabilitation with cortico-basal. And as I was mentioning earlier, we have a wide range of implant designs. Wide range. For those cases where you have ample bone, we have rough surface implants, which are called the KOS series, which you can see here. This can easily help those people who are practicing conventional implants. They can easily place the KOS implants. They are again single piece. And then you have the BCS series, which are the bicortical screw series. We have the zygomatic implants. We also have the BOI series, the basal osseointegration implant, which are lateral implants which are inserted through a open surgery. So we also have cases where you have a lot of tissue avulsion, tissue loss, including hard tissue loss. That is where you can use the basal, the BOI implants. Now, you can see this over here. You can see that the implant has been placed in a particular angle and the abutment has been bent. You can see the bending of the abutment here. So you can modify the implant to suit the available bone. You can see the sinus here. We've gone into the basal cortical bone. We've anchored it in the basal cortical bone, and then we could bend the implant. That is a beauty. And I need to mention here that Dr. Mahesh is here. He attended one of our programs, I think, way back in 2016 or 15. And he challenged us during the workshop. He challenged us, no, I'm going to bend and break the implant. Did you break the implant? No, we couldn't. We will just not break the implant while we are bending. It will break if the torque is very high. If you exceed 100 newtons, it will break, not otherwise. While bending, this will never break. That is the beauty of the metallurgy and the science behind. This case, now please remember, you need to learn the rules to break the rules. Here, there was absolutely no bone. So I had to put a small incision and raise the flap and then place the implant. You can see how I bend the implants. So whenever you have doubts, you're welcome to put a small incision to expose the bone and then place the implant. But whenever possible, try to go for keyhole. Now, these are keyhole implants over here, and we've modified the abutment. We've modified the abutment. We've trimmed the abutment. And there are special techniques in the prosthetic part, which Dr. Bobby will be enlightening you all about. So that is the classic difference. And then we have all our implants work on corticalization principles or cortical engagement principles. What is corticalization? We condense bone You would have heard of denser burrs. We've been condensing bone much before that, long, long ago. My mentor, Dr. Werner Mander from Austria, he was talking about condensing bone way back in 2009 when I met him first. He was using compression screws for condensing bone. And this is how you condense bone. We don't use burrs for condensation. We use compression screws for condensation. And finally, we finish it with the implant. So you can see how the condensed bone appears. And this is what we call corticalization. So it is either cortical anchorage or corticalization. This is what we do. And in the 4D implantology, what is the fourth dimension in implantology? What is the fourth dimension? Fourth dimension is time. Time is the fourth dimension. So Dr. Ide, our mentor, emphasizes on the importance of time in completing a case. Why? We finish cases in 48 hours or 72 hours maximum. Why? What is the reason? The reason is the callus stability. As soon as you've injured the bone is in a state of shock. It does not know what has happened. It takes about 72 hours for the bone to understand that some intruder is coming and something needs to be done to eject the intruder, and then the bone starts remodeling. This is what happens. Therefore, as soon as you have finished the osteotomy, you make the impression, you complete the prosthesis, and the prosthetic loading is, if the prosthetic loading is perfect, then you don't have to worry at all. Once you come to the phase of the bone remodeling, the implants hold, and they hold very well, and then it works very well. And then after 3 months, bone apposition begins, and after a year, you have mineralization happening. This is the reason why we do immediate loading. Please understand, many of my friends have told us, okay, you're trying to, some gimmick to prove to patients that you finish the work fast. It's not a gimmick, it is based on solid scientific evidence. We treat a lot of overseas patients. Almost 50% of my patients are international patients. So you can imagine all these people, they come here for 2 weeks, 3 weeks, and they have to finish the entire job and leave. So only cortico-basal implants can really help these patients. Now, a lot of people have told me, you place lots of implants. Come on, what nonsense. Why do you place so many? This diagram shows on the top slide, the X-ray on the top shows all on 4. As Dr. Priestley was mentioning earlier, it is either all on 4 or all on the floor. You understand? One implant fails, then you're finished. But having said that, I have seen patients in whom all on 4 has really worked very well. But I've seen many more patients in whom all on 4s have failed. But the moment you go in for multiple implants through keyhole methods, you anchor it in the right place, then you are guaranteed success. That is the beauty. This case is more than 12 years old. This is a case which I did more than 12 years ago. The patient was with me last week. I had to place implants for her husband, and I finished the case last week. So that is the kind of work we do. Whereas in the case of conventional implants, if one of them fail because of peri-implantitis, you are in trouble. Whereas in the case of cortico-basal, when you anchor it in multiple cortical areas, your success is almost ensured. And the other beauty is you eliminate peri-implantitis almost altogether. And the most important thing is the BIC, the bone to implant contact, is more or less the same in both cases, because in the case of conventional, you have a rough surface, so the bone engagement, the surface area is a lot more, whereas in the case of smooth surface, polished surface, the surface area is considerably lower. Therefore, more number of implants help in managing the BIC. This is a case where we finished the upper jaw in 72 hours, the lower jaw, it took more than a week for completion. So, and we avoid cantilevers. The prosthetic part is not shown here. In the case of the all-on-4 in the bottom, you have to provide a cantilever prosthesis. Otherwise, you can't complete the case. So we avoid cantilevers. Now, no interface problems such as screw loosening and screw fracture, which is another very important thing. Now, Wolff's law, form follows function. This is another very, very important thing. Wolff's law, form follows function. This is the principle we follow. That is, we place the implants, and once the implants are functioning, while during mastication, the function stimulates the bone and the form follows the function. Basically, you go to the gym and you keep taking weights, you develop muscles. Something very similar. This lady came in from the US in, you can see the date there, 12/6/2018. The implants were placed and the x-ray was done in 22/6/2018. You can see the bony defect here, the huge crater-like defect there. And this is the 3 years post-operative picture in 2021. You can see how beautifully bone has grown. Perfect bony integration, and the patient is doing very well. That is the top photographs are of the pre-op, and this is the post-op. As I mentioned earlier, there is no peri-implantitis seen in these cases. And the interesting part is these are isoelastic. They flex while in function. They slightly flex. So what happens? That stimulates bone to grow. Maintenance of occlusal loads. I always say, I always give a narration to the patient. I tell them, you just imagine you've bought a new sedan car. The car has got axles and it has got tires. So the tires are the teeth which we provided you on the implants, and the implants are the axles of your car. So in the case of, if you've bought a new car, you have to ensure that you do wheel alignment on a periodic basis. Otherwise, what will happen? The tires will burst at some point, and then you will end up in an axle fracture. So in order to avoid that, you have to do wheel alignment periodically. So likewise, you should do your occlusal maintenance corrections. And I insist on all my patients coming back to me for bite adjustments at least once a year. If not, they have to report to a local dentist and send me the documents so that the warranty on their implants they remain, which is very important. I maintain a perfect documentation in my practice. I have documentation of all my cases right from day one. It's been 15 years since I've started this implant practice. Every patient is documented. Everything is there. So any patient develops a problem, immediately I'm alerted by the patient and I'm able to advise the required corrective measures. Sterile loosening. What is sterile loosening? Because of the smooth surface property, if they get overloaded, you develop loosening of the implant. You can see this here. This is a BOI implant which is loosened, and it is sterile loosening. The moment you correct the bite, it heals and the bone reforms. That is the beauty of this system. Now, for those of you who are not interested in going in for single piece implants, citing retrievability, I have no issues with retrievability after having used more than 18,000 implants in the past 15 years. I have no issues because I have got my own way of retrieving the prosthesis. But some of them, they would like to use screwable prosthesis. We have multi-unit abutments. We have multi-unit implants available. Aesthetics, we are able to provide perfect aesthetics. Perfect aesthetics. Dr. Bobby will be showing you a lot more of slides because I am focused on the fundamentals. I'll not dwell more on the aesthetic part, but he will be able to show you. We are able to offer fantastic aesthetics to our patients. The emergence profile is excellent. This patient, I think Dr. George Artokaran will be remembering this case where she's a dentist. We managed this case is, I think it's more than 8 years now. So it's more than 8 years. Yes. You see the emergence profile of the patient. Perfect emergence profile. And this is a BOI implant which I gave more than 12 years ago. Perfect emergence profile. There is no contraindication in diabetics or smokers. In smokers, there is a relative contraindication. That is, in case the diabetic status is uncontrolled while we are placing the implants, then it is dangerous because the soft tissue healing will be affected. And the bone remodeling will also be erratic. So I always insist on having a stable sugar level for 1 year, and after the integration, even if the sugar level varies, this cannot affect the implant in any way. Likewise, smokers, we insist on them not smoking immediately after the procedure, during the immediate post-surgical phase. After about a month or so, if they smoke, nothing can really go wrong because the implants are all anchored in the basal cortical bone. And please remember, during the COVID era, and when you have lots of patients coming in from abroad, these systems are much faster and a lot more efficient for the patient. And we follow the facial buttress system. We anchor the implants in the buttresses of the face so that we are able to distribute forces in the right angles. So we use the vertical and the horizontal buttresses, and we use the tuberosity and the pterygoid implants. Dr. Priestley was mentioning about the pterygoid implants. I have a slight difference in approach. Here we use only smooth surface, and we anchor it in the cortical bone, in the pterygoid plates, which is very important, and we bypass the nerve, we bypass the sinus completely. Over here we have, this is a extra sinus implant and this is a trans sinus implant. We've gone through the sinus and then perforated the pterygoid plate. Over here, this is extra sinus. Okay? Here, you can see. This is a double pterygoid implant. Now, in a case like this, how do you perform implants? This is what we do. 4 implants in the interforaminal zone, 2 implants bypassing the nerve posteriorly, 4 implants in the intersinus area, 1 into the zygoma and 1 into the pterygoid. Okay? That is a typical case. Now, when you have knife-edge ridges like this, you have to open up, place the implants, close, and we anchor them in the basal bone here. We anchor them in the basal bone and we are able to provide solutions. I've spoken to you about the compression screw principle already. This is another depiction of how we place the implants and how we bend them. And mind you, these are smooth surface threads and this is a rough surface thread. This is a implant which replaces the normal conventional implant. This is what we call the BCSX, which is a highly polished implant. So here there is no question of periimplantitis. Here we attempt to avoid periimplantitis by providing the crestal threads which are highly polished and smooth surface. Here is a case, a very old case of mine. Picture in 2018. I did the implant in 2010. And this is the OPG from 2018. Here you can see a conventional implant in position. The problem here is the patient is developing periimplantitis. Here is another case of single implant, and such implants are more prone to food impaction and periimplantitis. You can see periimplantitis developing there. But this is how we do cases. We provide 2 implants employing keyhole protocols, and we connect them together, and that's it. We give an excellent platform, and the procedure is done in a keyhole fashion, and it is completed very fast. That is the typical depiction. The conventional implant is based on osseointegration. These are based on osteofixation followed by osseointegration. Is that clear? We osteofixate those implants in the cortical, and then over a period of 1 year, they osseointegrate. Whereas conventional, they osseointegrate within 3 months, 3 to 4 months. Why? Because they have a rough surface. These are smooth surface implants, so they take time to osseointegrate. It takes about a year or more for osseointegration. So our emphasis is on osteofixation more than osseointegration. This slide was prepared while I was in Luxembourg with a friend of mine way back in 2013. He wanted me to demonstrate how we bypass the inferior alveolar nerve. So that's how we bypass the inferior alveolar nerve. You can see how we bypass the inferior alveolar nerve with the implants, and you can see the nerve has been bypassed and the implants have been bent. You can see the angulation of the implant here, the abutment, and the abutment has been bent to ensure that the prosthesis fits in properly. And this is one of my oldest cases when I did the nerve bypass after opening up the area to ensure that I don't injure the nerve. I think this is more than 12 years old now. So you can see how we bypass the nerve in these slides here. And these are some of my old cases where we did immediate loading. This patient came in from the US, and she had terrible loss of bone, and we extracted this tooth and we provided her with immediate implants. And here is another case of internal sinus lift achieved automatically without putting in any kind of bone graft, because the implant has lifted up the sinus membrane and subsequently the bone filled up in the area. So the maxillary tuberosity implants, I think we've already covered. I think there is a duplication of the slide. Now I come to the zygomatic implant. We have the zygoma implants here. Wherever you have lack of bone, severe atrophy of the maxilla, we use the zygomatic implants. The zygomatic implants can be used extrasinus as well as transsinus. Extrasinus and transsinus. And then we have combinations of implants, implant designs. The QS Plus implant, where you have a combination of the crestal design and the basal design. All these designs are available. This is a relative of mine for whom I placed these implants more than 10 years ago, doing very well. You can see how we bypass the nerve and we've engaged the sinus flow. You can see that there. You can see how we engage the sinus flow, the nasal flow, the pterygoid, and see that? This is a case from Dr. Vivek Gaur, my friend in Delhi. They had a lot of mucormycosis cases. So the zygomatic implant has been used as a glabellar implant here. It has gone into the glabella between the eyes. Okay? So the zygoma has been used not just in the zygoma, it has gone in as a glabellar implant, and the prosthesis has been given, a frame has been created, and an overdenture prosthesis was provided. And here is another case where the fibula grafting has been done, and in a CA case where the patient had to undergo hemimandibulectomy, and you can see that the zygomatic implant has been used in the mandible to help in the rehabilitation. So all these are possible. Here is a case of mine which is more than 10 years old. You can see how the implants are engaging the nasal floor, how the implants are engaging the pterygoid. You can see the pterygoid implant. this patient is from Cochin and all her relatives are all, they keep visiting us for frequent checkups and maintenance. So I keep seeing this patient on a regular basis. When I posted the OPG of this patient way back 10 years ago, Dr. Gregory Kudzman from the US, he criticized me. He said, all these implants are going to fail. And then I told him, see sir, you have to understand the positioning of the implants before you comment. And that was when I created this video. And the patient is doing extremely well. You can see the pterygoid engagement there. The pterygoid, you can see how we bypass the nerve. That is how we bypass the nerve. So let us remember the fact that patients are coming to us for fixed teeth and not for implants. And dental implantology can be truly successful only if there is excellent teamwork. So the team is the implant and the implant supported prosthesis, the surgeon, the team, again the surgeon and the implantologist, and the prosthodontist and the dental laboratory. So I always say it's a family affair. The husband is the implant, the wife is the prosthesis, and you have two children, aesthetics and function. If there is a family problem, then you're finished. Yeah? I treat a lot of international patients. This was a group of Australians who came in way back in 2013. I just wanted to show this. And Dr. Ide says, for me, implantology starts where others gave up. Strategic implants also offer a unique opportunity for the implantologist to treat cases which cannot be treated with the other conventional implant systems. And before I conclude, I need to emphasize on a few things. This is the era of artificial intelligence. Okay? Another 10 years from now, I'll not be surprised if robots start interpreting our cases. They'll say, you've not done the right root canal. Your root canal is wrong. That is why it is infected. Your implant is not placed in the right direction. It is wrong. Okay? Your filling is wrong. Your prosthesis is not fitting properly. Okay? Your orthodontic planning was wrong. And your orthodontic surgery planning was wrong, which is why you ended up skewing up this case. All these are possible. Now, so how do you overcome this? You can overcome this only by doing the best you can do in your profession. That is, be focused with what you can do the best and create a team so that you're able to offer the best for your patients. And then you have to document cases, which is the most important. I have documentation for the past 30 years, 29 years. I have all my files still. Whenever my old patients come in, I keep adding. Now we don't follow the written protocols. We save everything online. So we keep updating all our old patient files whenever they report for review. This is what we do. And it brings in a lot of relief. And patients are very happy when they see that all these files are maintained. So it's extremely important, and also try to get consent forms signed, which is very, very important. Otherwise, you'll invite medico-legal issues. Thank you very much. I hope I've been able to give you an overview. Are there any questions? Otherwise, I'll request Dr. Bobby to come over with... Okay, perfect. Bobby.
Good evening, everyone. I know you had a long 2 days and just want to complete and go home, so I'll be quick with this presentation. So I'm Dr. Bobby Anthony, and I'm going to present to you the prosthetics on cortico-basal implants. So what is the importance of prosthetics and occlusion? See, when a patient sits on your dental chair, she's not going to ask you, can you give me cortico-basal implants or zygomatic implants or noble biocare implants? They're just going to say you, give me fixed, functional, and most importantly, beautiful teeth. And this is where the prosthetics and occlusion comes in. And that is only the patient's part. As an implantologist, it has been proven beyond doubt that it is the prosthetics and occlusion which will determine the life of your implants, whatever your implant system be. If it's conventional, it will be just a delayed failure. If it's an immediate implant, the failure will be faster. So you must make sure that so however great your surgery is, if your prosthetics and occlusion is wrong, you can be sure that the implant will have some problems later. So which material do you choose to fabricate the prosthesis? So we have many materials available today. So I'll just take you through a couple of them. So metal acrylic, what is the advantage of this? It's easy to fabricate. It's most commonly used material for an interim prosthesis. And because you have acrylic teeth, even if your occlusion is not that proper, you can make changes even after the prosthesis is acrylized by grinding, and while the patient is chewing, the occlusion gets self-corrected. So in that way, metal acrylic is advantages. But what are the disadvantages? It has compromised aesthetics. Some patients don't like the pink acrylic. Some people don't like the finish of acrylic teeth. And it's prone to fracture. And you can see after 1 or 2 years what happens is, because of the wear of the acrylic teeth, there is a loss of vertical dimension. So then you will have to increase the vertical dimension, you will have to add the composite or acrylic. Then you have metal ceramic. It has great aesthetics. It's the most commonly used material for your permanent prosthesis. But what are the disadvantages? It's difficult to repair if there's any kind of chipping. And it cannot be used in cases where there is where you need to replace a very high vertical dimension. This is because of the weight of the prosthesis. There'll be a lot of metal required, and that will increase the weight of the prosthesis. And I say that ceramic is an unforgiving material, because if your occlusion is not correct, it immediately doesn't wear off. It transmits this force, this overload, directly to your implants. So that is why I don't like using metal ceramic as my first prosthesis. And also, if you have to make corrections, there may be chances for a metal exposure. The other material that we have is metal composite. It has good aesthetics. It's easy to repair if there's any kind of damage. And also, again, like metal acrylic, if there is any occlusal imbalance, it's easy to correct. So what are the disadvantages? It requires a lot of specialized material, and it's a bit time consuming to fabricate. So if you want to complete your case within 70 hours, it's a bit difficult. Then you have zirconia, again, which has the highest aesthetic for all materials. It is very suitable for the anterior crowns or small segments. But the disadvantage is when you go for a long frame, there are chances that it may fracture, and again, that may cause failure of your implants. So how do you choose which material to fabricate your prosthesis? So you should remember this point. The clinical situation dictates your prosthetic options and not your patient's budget or desires. This is a very important point that all implantologists who are starting out should remember, that you should be in charge of your treatment plan and not the patient. So what are the different clinical situations we can encounter? Suppose there's multiple extractions, so I'll go for an interim prosthesis because metal acrylic is easy to remove, and I can go later for a second prosthesis like metal ceramic. When I'm placing the implants, suppose there's low mineralization of bone and I don't get enough torque, again I can go for a process like metal acrylic, which is again lightweight. If there is a high vertical dimension, again I don't want to go for metal ceramic, which will be very heavy, so I'll go for metal acrylic. So suppose there's only single or no extractions, then you can go for a permanent process like metal ceramic. Single tooth, small segments, you can go for zirconia. Completely edentulous, again you can go for metal ceramic. So I'll quickly take you through the fabrication of the prosthesis. So these are the steps involved. So you could think, like, why should I learn about the fabrication of the prosthesis? This is and I used to think that way. I did the difficult part of placing the implants, and now it's the problem of the technician to fabricate the prosthesis. This was, in my initial days, I used to think a lot like this. But what happened later was my consultations were taking me very far away from the lab that was doing my work. So then I had to start doing my own lab work, especially like in the Gulf when I had gone. So then I realized that the position of the implant heads was making, to fabricate a prosthesis was very difficult. So then I started placing my implants. So doing my own lab work helped me to improve my surgical skills and place it in a better position so that the technician was able to make a better fitting prosthesis. This is even true for your crown and bridge. So if you sit with your technician after preparing a tooth, and you sit with him and fabricate a crown, you understand what are the difficulties he's placing, and you can improve your crown preparation skills. So quickly I'll just take you through the steps. First is the cast visualization. You make sure the number of analogs is similar to the number of implants. The entire abutment of the head is visible. Remove air bubbles from the cast. And we trim the implants. This is done by the technician. So this is actually a reverse engineering which is done in CORTICO BASAL. Instead of the the doctor trimming the implant heads, the technician is trimming the implant heads. This is because we are taking implant level impression, and that is why whatever the technician trims, and he makes a proper fitting processes, and we duplicate what he has done on the cast on the patient's mouth. So how is this possible? How will I know how much he has trimmed? There are two methods. One, he can make a jig for you, or how we follow is that the technician is not allowed to touch 3 mm of the cervical portion of the implant. So he can cut like this, or even like this. But still, he or me or the technician can't touch the 3 mm. So this is where the metal frame is resting. So whatever is above that is inconsequential. Next, we place the burnout caps. Now we roughen the burnout caps so that the pattern resin frame, which is used to create the frame, is able to mechanically lock into these burnout caps. The roughened burnout caps are placed on the cast. The pattern resin is connecting the burnout frames. And if you want, you can use this pattern resin frame, and you can trial this in the patient's mouth to check if your implant positions are correct. This pattern resin frame is casted into metal. The connectors in between the implants should be at least a minimum of 3 mm in height and 2 mm in width. This metal frame trial is trialed in the patient's mouth. So as I said, we cut the implants as the technician has cut, in the same way as with the help of a jig, or arbitrarily as we know how it is. Because the implants, as Sir was explaining, are isoelastic. So they flex a little. So they will accommodate the frame when you push it in. After that, a wax bite is taken and the vertical dimension is recorded. The metal frame with the wax bite is taken out and re-articulated. The teeth setting is done. The wax trial is done on the patient, and it's acrylized. In the case of ceramic, we have a slight change in the procedure. The pattern resin frame is made in the form of teeth because the metal has to follow the ceramic. This is casted into metal and tried in the patient's mouth. The vertical dimension is corrected, and then the ceramic this is the finished ceramic prosthesis. Now I'll quickly take you through a few cases showing the different materials. So zirconia crowns and basal implants. So this patient came from the UK. He had sent me this OPG and said he wants to remove all his teeth and place implants. I wish all my patients were like this. But the thing is that I really counseled him. You should do at least some kind of perio treatment and get the bone loss fixed. But he was adamant that he wanted to remove all his teeth and get implants done. So this is what we did. We placed 10 implants in the upper and 8 implants in the lower. And we gave him a interim prosthesis with metal acrylic. So we had agreed that because I had a huge amount of vertical dimension to restore, that we'll go for a metal composite prosthesis when he returns. But what happened was COVID happened, and then he could only return after 2 years. And after this, he said he was adamant he wanted zirconia. Now, I was a bit worried because if I was going to give such a zirconia frame on a high vertical dimension, I'm sure it would fracture. So I sat with my technician, and what we did is, we again re-articulated the bite. We scanned this, and then what we did is we made a titanium frame and made abutment-shaped individual teeth. And then we cemented this on the implants, and then took an impression of this, and then we made zirconia crowns on the abutments, and we individually cemented it. So with the help of this, without breaking the prosthetic principles, we were able to satisfy the patient. Next case was a metal composite prosthesis. Now this is a 32-year-old girl. She's a nurse. She had two problems. One was that she was not happy with the size of her central incisors and also with a gummy smile. So again, we counseled the patient. She said she wanted to remove her upper teeth and get implants done. Again, there is another thing that in cortico-basal implants, we are supposed to, treat the case as a whole. So that is, even if the patient wants the upper, you must make sure that the patient is able to chew on both sides. Otherwise, there will be overloading on one side. So we had told the patient that she has to rehabilitate her third quadrant also. Otherwise, we are not going to do the case. So she agreed. So finally, we extracted all the teeth, we placed the implants, and I did some alveolar cutting because she wanted to remove, she wanted to get her gummy smile away. So what I did was I just kind of removed a lot of the height of the alveolar bone and then placed the implants, and this is the metal composite prosthesis. As you can see, we were lifting the lip to expose the teeth, so her gummy smile was fixed and the size of the central incisors were reduced. Again, this is how you satisfy the patient's desires. You can also do overdentures on basal implants for those patients who can't afford a fully fixed prosthesis. You place 4 implants in the interforamen area like this, and we can place a metal frame, we can fabricate a metal frame and cement this. And then you take an impression of this and then create a denture, and you can put soft liner. And now in our metal acrylic prosthesis. This is a very interesting case. This boy is 18 years old. He is a denture wearer since he was 8 years old. He has only 4 permanent teeth. He has a history of ectodermal dysplasia. So when I was talking to the patient and counseling him, he was telling me that the principal in his school was promoting his friends and the same teachers from UKG till 12th standard because they didn't want him to develop the stigma of not having teeth. So he told me, Doc, I've finished my school, now I have to go to college. I'm only going to college if I have fixed teeth. So I told him, okay, let's see. So we got the OPG. So yes, it's a bit of an atrophy in the mandible as well as in the maxilla. So I said, okay, there are some places where we can place bone. Okay, it looks okay. Some points we can. And so next I said, okay, let's get a CT done. Then this is the case. See how thin the bone is. In fact, it's not only here, almost everywhere this is the situation. In fact, the line that the radiologist was using to draw, to show the length was thicker than the bone. So finally, I'll just show you the pre-op clinical photos. This was the 4 teeth that he had in the upper, 1 tooth in the lower. This is the bite that he was having, and we finished the case like this. So I gave him a metal acrylic prosthesis because he did not have a known occlusion. So I gave him a little bit of high vertical dimension, and we were reviewing the case around every week. And then after around 1 month, he got into a proper bite. So this is the photos before and after. You can see in the before how he's very shy, he's apprehensive, he's just going for the procedure, doesn't want to smile. And this is 2 years later, how confident he is to smile. So, and now he's going to college and he's doing quite well. So basically what I want to say is to all the implanters who are starting out, see, you will definitely encounter failures. All the speakers who have been speaking on this podium have faced failures. It is what you do after the failure. Dust yourself off and get up. And then if for the majority of your patients, if you're able to improve their quality of life by just making them smile, you fulfill your purpose as an implantologist. So thank you. Thank you so much to the SPIK, COPS and all the IDA for giving us the opportunity to present our views. Thank you.